Well, good morning and good afternoon, everybody, wherever you might be. This is Dr. Gwilliam. It is, as always, a pleasure to present to you and to speak, and I'm always honored to be invited to speak for ChiroHealthUSA. And what I'd like to talk to you about today is the perfect soap note. And I have to confess right off the bat here that I purposefully gave it this name to draw you in and get you excited to think, there's the solution I've been looking for all these years. There is one simple, perfect soap note I can just use. And the truth is, there really isn't. But I'll show you what I think was a really good one, because there's so many different authoritative sources out there that want different things. There isn't really one simple solution that satisfies everyone, but we'll sure give it a try, right? So I'll do my best to share with you what I know and what I think makes the most sense. I am the clinical director for PayDC, which is a cloud-based, compliance-focused EHR system. And some of you may know me from ChiroCode. I was previously with ChiroCode for 6 years, and I was vice president of that company. For those who don't know ChiroCode, ChiroCode's been around since the early 90s. And main thing was a book that it still is a book, the ChiroCode Desk Book, which tells everybody in chiropractic how to deal with insurance billing and Medicare and how to create great records and what auditors are looking for. And so I know a lot about this from that experience. During my time with ChiroCode and now with PayDC, I travel frequently and I speak at seminars, and I'm often sponsored by ChiroHealthUSA. And so that's my relationship there is ChiroHealthUSA likes to help get me out to your state associations and get this message out about how to be compliant and create good records and code correctly and all that fun stuff. As you can see, I'm a bit of a certification junkie. I'm a chiropractor with a couple of other degrees. Those are actually business degrees with a focus on accounting. In fact, let me show you. Here we go. And then I have a lot of certifications. I really got into this for a while, and they basically are the things I've done so that you don't have to, right? But I want to point out that I'm a certified professional coder. I'm a medical compliance specialist. I'm a certified professional medical auditor. And so I also do work for attorneys when doctors get in trouble. I've also been hired by doctors who are having to respond to things from their state boards. And so, for example, I'm working with a client. I just met with them a few days ago, and I've been appointed by his state board to meet with him. It was monthly, and now we're down to once a quarter to review his documentation and report back to the board because he got in trouble for having lousy records, and he paid a fine. And part of his quote unquote punishment, I guess, was he has to meet with me. And we get to hang out once a month, and then I send a report to the board. So I know what's going on out there. I've been around the block a few times. I know what the issues are, and so I have been teaching this around the country for I'm going to say 8 or 9 years now. I've been traveling, doing seminars, and so I've been working with ChiroHealthUSA for most of that, and it's been great fun. Anyway, and there's a picture of me. Fairly recently, so that's what I look like. So, by the way, if any of you are looking and getting certifications, shoot me an email. I'll tell you which ones are worthwhile and which ones are just letters after your name for fun. A little bit more about me before we dive into this stuff. This is my brood. Yes, I'm a single dad with 6 kids, and there's all my little ones. Not so little. The one on the far right, my oldest, actually photoshopped in the head of one of the other ones because that child was frowning. Anyway, you can look at this and try to guess which one is photoshopped. I think she did a great job. It's hard to tell. So anyway, that's me. I live in Utah. You can see the snow. But I get around, and if your state association is looking for somebody, I'm happy to come out and speak. So just let me know. And ChiroHealthUSA loves to help me get out there. So here's what we're going to talk about today. This is the purpose of our little meeting this morning/afternoon. I want to talk about payer requirements for documenting SOAP notes, and I want to get a handle on the correlation between SOAP and CMS requirements or Medicare. So a couple thoughts here. payers, many of them have policies or other guidelines that say, hey, this is how we want notes to look, and this is the minimum requirements. These are the things we expect to see, so we can make sure that the care was medically necessary and where you have to pay. By the way, many groups call these treatment visits as opposed to like daily encounters or subsequent visits. In other words, I'm not talking today about the initial encounter or re-exams, which are a little bit more robust, where you have to do a little bit more work to provide greater detail, especially if you want to code for an E&M encounter. I'm talking about a typical daily encounter, what really needs to go into the records for those typical notes. And I think SOAP is a terrific format for that. It's really the standard for most entities. One in particular of great note is Medicare. And so even if you don't take Medicare, you need to know what Medicare requires, because they are a good gold standard. If you can satisfy Medicare, you can satisfy just about anybody. So the last half of this presentation, we're going to talk about matching up SOAP notes with Medicare, because interestingly enough, if you look through Medicare's guidelines, I've never come across anything that says that they require SOAP notes, that format. But I think that you can use that format to satisfy them. I think SOAP is a pretty good model, and it works with a little bit of understanding and tweaking. It works for all payers, including Medicare. And by the way, it is Medicare that calls them subsequent visits. That's how they refer to them in their guidelines, these daily encounters or treatment visits. Again, they distinguish these from examination encounters or reevaluations. And I have a disclaimer. This is what I think is a perfect SOAP note. Medicare might not agree if you follow exactly what I'm teaching here, and Medicare says, well, that sucks. And I just want to say that I could be wrong. In fact, everything I share with you in this presentation today could be wrong. And now that I've said that, I've covered all my bases. This could be flawed, and we may get some feedback here at the end of the presentation where some of you say, wait, I wouldn't do it that way, or I like it this way. That's great. Let's have that debate. So I'm planning to set aside some time here to do some Q&A, because I want you to, I want to debate a little bit. I think some of you are going to disagree with me, and I respect that. I think that discussion, even though it's one-sided because I'm the one with the microphone, could be beneficial to the rest of the listeners here. And let's see what we come up with. All right. But I'll do my best to share with you my view and what I think makes things as simple as it can be. I want this to be easy for you and not complicated. And so I'm going to try my best to make things straightforward and simple. And I want you to be able to create good records without having to slave over it or find that you're wasting a lot of time on administrative tasks, because really what you want to do is take care of patients, right? Get them in, take care of them, send them out, get paid for it. And nobody wants to spend more time creating notes, except maybe me. So I really hope I can help simplify what goes into your records. I mean, this is one of the reasons that I became the clinical director for an electronic health record company, because it gives me an opportunity to take a product and put my touches into it. PayDC was already great. It's why they recruited me over to work for them a couple of years ago. But I've been able to put a lot of what you see here into that system, and that's exciting for me to be able to do that, because I think that for a lot of us, if we can just see our patients and get on with our lives and not dwell on administrative tasks, I think that we'll enjoy what we do. And I think being a chiropractor can be fun, and creating records shouldn't be a tremendous burden. So let's get into it, shall we? Back in, I believe it was 1967, there was a medical doctor by the name of Dr. Lawrence Weed. And I don't know why, but I have his name memorized. I think it's kind of funny. Dr. Weed, he'd be welcome today, I think. He came up with a concept called the Problem-Oriented Medical Record, or POMR for short, Palmer. Because he said, look, the way that we do medical records is back in the 60s. It's confusing. There's just stuff in there. We need to have a standard. And so he came up with this and proposed a standard, and it was accepted. And this is used by most credentialing agencies today, the Palmer method. Basically, this type of record answers these 4 questions. It's, why did the patient begin care? What did the provider find wrong? What did he or she do about it? And how did care end? And so I want you to ask yourselves, hypothetically, you don't have to do this out loud, but if I looked at your records right now, could I find these 4 answers? If I looked at a daily visit, could I see the answer to these 4 questions? And if you realize, if you're being honest with yourself and you say, I don't really see the answer to these questions, like, I don't understand why the patient started care. The doctor just started providing treatment, or, I don't really know what the provider found wrong because all that's listed there is neck pain and a subluxation. That doesn't really explain anything, or very little, I guess, the doctor found wrong. What other musculoskeletal condition was there? What did she do about it? Most of your records say, I did an adjustment, or I did, e-stim or something. But here's a question for you. Did you plan that, or did you just start doing it because it's your clinic happens to have an e-stim machine, so that's what you did? Or you have intersegmental traction, so you do it. Or did you plan to do it with a goal in mind and a purpose for that service? And then, of course, every daily visit doesn't explain how care ended, but it needs to have an end in sight. So here's a dumb joke for you. It's how many chiropractors did it take to screw in a light bulb, or does it take to screw in a light bulb? And if you haven't heard this one, the answer is, of course, it only takes 1, but it will take 10 visits, right? That's the way that physical medicine works. And so, care ended once this light bulb was screwed in, but it took 10 rounds to get it done. If we expand on the problem-oriented medical record concept a little bit, there's really 6 pieces to it. And SOAP notes represent step 5. So if I say send me your medical record and send me your SOAP notes, in a sense, I could say you're only sending me a 1/6 of the record, because there's 5 other things that need to be in there. Number 1, there needs to be a complete problem list. 2, a diagnosis for each problem. 3, treatment goals for each problem. 4, a written treatment plan for each problem. And then finally, 5 is the SOAP notes, where you explain how all that was followed. Now, the SOAP notes are going to represent the bulk of the volume of like a paper chart. If I had to open up a paper chart, on the left, I might see this handy little list that lists the 4 things that you see there, the first 4 things. On the right might be the thick stack of SOAP notes that say, well, on March 3rd, we did this, and on March 8th, we did that. And that's kind of how this fits together, right? The SOAP notes simply outline what follows from what you had specified in the first 4 parts of this problem-oriented medical record. And then at some point, the patient reaches maximum therapeutic benefit or discontinues care or is discharged. And that's where number 6 comes in. And you can put that also on that left-hand side, the inside cover of the chart. Where you say, okay, we had this plan. On the right, you can see all the things we did for that plan. And then finally, here's how it was resolved and when they were sent out, or they were discharged, whatever it was. And so an ideal medical record provides this information in an easy to spot way. And I'm kind of referencing the old-fashioned paper model, but I know that around half of you are still using paper records, and that's okay. I'm just suggesting to you that the problem-oriented medical record is a clean way to capture that kind of information. So another way to look at this, or my own kind of spin on this, is this thing I call the episode of care road trip, if you will. So let's suppose that I load my 6 kids into my minivan, and we decide to leave here. I live in Utah, about 45 minutes from Salt Lake City. So I load my kids in the van. I said, kids, we're going to Yellowstone National Park. It is, it's about 300 miles to the north of where I live, give or take. I should look that up, but it's almost due north from here. And to get to Yellowstone, you have to leave. You go from Utah through Idaho, and the entrance in the city of West Yellowstone is in Montana. Okay, and it's about a 6-hour drive from where I live. And several years ago, I think it's been 3 or 4 years ago now, I did this. I took my kids on that trip, and we camped there for a few days, and then drove back. So in order to plan out this road trip, I might sit down with the kids and say, all right, let's get out the map. Let's take a look. We need to go north on Interstate 15. And when we hit Idaho Falls, we turn onto Highway 20 something. And we stay on that one for several miles. And then we get off on a slightly smaller road, and we work our way until we end up our destination. And then we get out at our destination. We look around and hope that we've arrived there. Right. So the way this works with patient care, it's the same thing. You start off by gathering the kids around and saying, where are we going to go, kids? How are we going to get to our destination? And you make a plan. You might say, this patient's going to receive this many treatments. We're going to do these types of services. And we're hoping to accomplish these things with these services. And if these things are accomplished, we'll know we've reached the end I know I've arrived at Yellowstone because I'll get out of the car and I'll look around and I'll see geysers and I'll see bison and I'll see beautiful mountains and I'll go, oh, yeah, I'm here. And the question for you is, how do you know when you've reached the far right corner of this map with your patients? How do you know when you can discharge them and you've accomplished your goal? You also need to stop once or twice in the middle with an interim evaluation, like I have in the center here, and decide whether or not you're still going the right direction. Like with my kids, if I pull off in Idaho Falls, halfway between here and Yellowstone, I need to get gas. I need to maybe feed the kids. We need a potty break. And so I stop and I look around and go, okay, we have plans to go this way. Do we still want to go this way? Like in this example, I'm on Disc Degeneration Highway for about 10 visits with that eval kind of around the 7th visit on Disc Degeneration Highway. The question is that accurate? So I get out and I look around and I go, no, you know what? It's not working. The patient's not progressing the way I expected. So instead I turn south on Neuropathy Lane and then right again or left again on Zygapophysis Way. In other words, I'm trying to still get to the goal, but I have to change what I'm doing. Maybe I provide different exercises because the patient's not responding, or I switch from activator to Gonstead because that's what is going to get better results. And so I want you to understand this model, because today what I'm focused on mostly are those ones that are just in the circles with the T, which is a treatment visit. That's what we're looking at, focusing on today. I'm not diving into these bigger evaluation visits, which take a little bit more effort and include an E&M encounter. I'm talking about typical daily treatment encounters where the main thing you're doing is an adjustment, maybe some exercises, maybe some modalities. And the point is, I want to be able to say, if I'm at this 8th visit here, it's like if I'm on the freeway and I see that I just passed mile marker 15, is that closer or farther from my destination? Am I still heading north, or have I veered off and started going to, in other words, with your patient, are things going the way they're supposed to? And so you need to be able to demonstrate from one visit to the next. And this is key. This is the key for this map that I'm going over, is I need to be able to see that from one T to the next one, there's been change, there's been progress. So I need to be able to show that I'm getting closer to a destination. I've gone farther down the road. I've passed another mile marker. Because alternatively, your care could look like you hit a traffic circle and you just drive around that circle forever. You're treating a patient over and over and over again with no goal in mind, with no measurable changes. And that is not acceptable to most payers. They won't pay for that type of care. You need to show progress on a linear fashion away from the origin and towards a destination. And if you're circling around and around in a traffic circle and not getting any closer to Yellowstone or a point where you can discharge the patient, then your care may not be payable. Okay, so my main message today is that your daily visits should reveal that the patient has progressed, that there is change from one visit to the next, and that you're flexible and that you're willing to take a different direction if necessary. And you'll discharge the patient when they've stopped progressing. Maybe on the road trip with my kids, we learned there was a forest fire and we had to stop and go back, or pull over at a lovely hotel in Idaho Falls and spend our vacation time there in the hotel pool instead of playing with the bison out in the plains. I have to accept that we may not be able to get to that destination we had originally planned. And so you need to be able to do that with patients as well, and either discharge them early or change course or something. So enough of this parallel, but I think you get the gist of it. You understand that message. So what I want to do now is share with you, I think I have 5 different sources of what is required to document these visits. This one is from Optum. So what I've done here is I just got a list of Optum's daily visit requirements, and on this is one of their policy bulletins. They said there are 4 things that need to be included in the daily visits for chiropractors. And so they say that there needs to be a subjective record of the patient complaint that explains the location, quality, and intensity. Number 2, there has to be physical findings that support manipulation in a region or segment at a minimum. Number 3, there needs to be an assessment of change in the patient's condition as appropriate. And I should have highlighted the word change because I really think that's key for these daily visits, because I see as the reason for denial more than anything else is that there wasn't enough change, that the change wasn't obvious, and therefore the care wasn't medically necessary. And then 4th, a record of the specific segments manipulated or the services that were performed, right? So this is just from one authoritative source. Optum is United Healthcare, right? For those of you who deal with them, they actually expect to see these elements in a note. And you might look at this and go, oh, that sounds a lot like what I know of as a SOAP note. And it does. That fits pretty nicely with the SOAP note. Let me give you another example. Here is some requirements from Blue Cross Blue Shield of Louisiana. I did a seminar there back in December of 2018. And so I pulled this and stuck it into this presentation as I was teaching this to that group. They have 7 things they expect to see in daily notes, and they don't really go in order here. They just dumped 7 things here. They said they want to see documentation in addition to and in support of a flow sheet for every treatment session. And they're referring to the flow sheet to describe the therapeutic procedures. They want patient feedback. They want concrete measurements. They want treatments performed, frequency, duration, and equipment used. So that's a lot of detail around what you're doing. If you're doing eSTEM, they want to know about it. They want an assessment of patient's progression, or that's change, right? They need to know the patient's moving along. And they want a continued plan or discharge note if it's the end. And they want to know who the licensed provider is that's performing that service. I can tell you that I conduct chart audits as well. A lot of people send me records, and for a fee, I'll review those records and provide feedback. And I have a scoring system that I use for that. And I often am knocking points off of a provider for their signature. You think that'd be an easy one to do, but I see things like multiple doctor's offices where they don't identify which doctor it was. They have a scribble at the bottom, but I don't know whose signature it is without an attestation log, or better yet, they circle their printed name and then they sign it, that type of thing. And so electronic records kind of solve that by always printing the name adjacent to an image of the signature or saying, electronically signed. And so that's just one of the little elements I think is important. Okay, and this is just one other authoritative source. This is Blue Cross Blue Shield of Louisiana, but there are many others out there. In the state of Colorado, they have this thing called Rule 22 in their statutes. In order to become a licensed provider in Colorado, you agree to Rule 22. And I know some of my friends over there find this to be burdensome, but actually I look at it and it sounds a whole lot like a typical SOAP note. In fact, this one looks more like a classic SOAP note than the others that we were just looking at. But I'm just pointing out here's another authoritative source establishing their authority by saying, here's what we got to do. Here's what's required of you. Number 1, a subjective complaint, right? We say, the patient's description of complaint should be recorded at each visit, indicating improvement, worsening, or no change. Right. So the patient came in originally with neck pain. You need to say, what does the patient feel like? It's getting better, worse, or no change. Every encounter, every established patient visit is what they call it, needs objective findings. So this is where you put changes in the clinical signs of a condition. And so if their range of motion has improved, or if they've, there's less muscle spasm, there's other clinical findings, they need to be documented. And if every single visit, for 20 visits, you simply say, decreased intersegmental motion and muscle spasm on the right side of the neck, and you say that same thing every time, doesn't that sound kind of like the patient's not progressing? That there's been no change? And you say, well, but that's what I'm finding, and that's what I got to do with the neck. But an outsider, an auditor could, or a peer reviewer could look at that and say, well, that sounds a lot like care that wasn't necessary because you weren't changing them, you weren't improving them. So do your best to identify objective changes as much as possible. Okay, I'll talk about later. I understand that things don't always change between every visit, right? Sometimes you see them on Tuesday, you see them again on Thursday, and it's more or less the same findings, and that's okay. But I'd say only for 2 or 3 visits. When you hit the 3rd or 4th visit and you're describing the exact same findings and the exact same complaints and all that, then I think it can be argued that the care isn't showing enough progress and you need to show changes. In fact, one payer, Aetna, actually has in their policies that if you can't show change within 2 weeks from beginning care, some sort of change, then you won't get paid for care anymore. You get 2 weeks to show some change. And if you can't show change, but you're able to adapt the care and say, well, we were doing it this way, but now we're going to try this. And you take a slightly different direction. Like on my roadmap, you take a different roadway because that one's closed due to snow or whatever. You take a different path, they'll give you 2 more weeks. Aetna will do that. And if at 4 weeks you still can't show change, then you're done for sure. So at 2 weeks you're done unless you can change what you're doing and you have another chance to make progress. And at 4 weeks, they'll say, we refuse to pay for more than 4 weeks of care. And based on that model. So it's critical that you show changes. And I think, about 3 visits is as far as I think you should go without having something in there that says, even if you just say, I'm finding the exact same muscle spasms, the exact same segments that aren't moving. But here's why. because the patient goes to work every stinking day and does the exact same thing on this widget machine, moving the same way, and I can't get ahead of it because of their job. So we're going to try this more intense exercise regimen or something. So in other words, if there isn't change, then acknowledge it. Don't ignore it, and explain why you think it's there and why you think care is still going to be helpful to them, even if you can't get change very fast. Maybe what you explain in the assessment, this is kind of number 3 here, in the assessment is, the patient hasn't changed much, and it's been a week and a half, 2 weeks, and I've seen him 4 or 5 times. Just say, well, I think it's because they have diabetes and the body doesn't heal very fast, and so it's a challenge due to this underlying comorbidity, this physical ailment that makes it so that they don't heal as well and they aren't as responsive. I can't do as aggressive as treatment. Just acknowledge those things. That goes a long way when it comes to getting audited and reviewers. And so Colorado's Rule 22 says the assessment doesn't have to be updated every visit. However, reevaluation should be performed and documented in the daily entries. Reevaluations being those interim exams in my map, my road map. It's when I pull over halfway through my trip and I get out the map and make sure I'm going the right way and there isn't a better path due to, traffic or snow on the road or something. So if the diagnosis does change, it should be documented. And this is where you can discuss the prognosis or the outcomes. You can say, I thought the prognosis was good, but now I'm thinking maybe it's only fair. And, with an electronic health record system like ours, it's just in the drop-down menu. You just change it and away you go. So make sure that you've assessed that. Number 4 here, they say and notice that this is a SOAP note. The 1 through 4 all start with S, O, A, and P. So it's going to follow the classic SOAP note model, which is subjective, objective, assessment, and plan. But they've got 2 Ps. And I like this. I think that it's useful to have 2 Ps, plan and procedures. Plan is, this is what we started with. We plan to do, a dozen visits or 18 visits or 24 visits or whatever it is. In the P, in a typical daily encounter, you say, we're following the plan. We're not changing anything. Or original plan said we were going to see them this many times a week, but I think that they're doing so well, we're going to cut that back to this many. And this is where you can say, hey, we had 3 phases of care, or stages of care is what I like to call them. And I think that it's important for you to set up care plans with different phases. And you say, hey, the first phase of care was the first 4 weeks, and now we're in the next phase. And so that's where this belongs, in the plan. If you decide to change the settings on the eSTEM, this is where you could document that, and so on. And then finally, number 5 is the procedures. And this is where you outline what you did that day. You say, hey, today we did chiropractic manipulative treatment. We did eSTEM, and we had the patient do some stretching exercises. And you describe it. What kind of procedure is it? Where is it being done? Is time a factor for this particular procedure, such as it is with therapeutic exercises or manual therapy like trigger point? So this is where you capture that information. So you can see that Colorado's got it pretty well outlined in their statutes, but they're not the only ones. Here's another authoritative source. This is a provider network out of the Midwest that I did some work for several years ago, and they asked me to do a presentation on creating ideal notes, and they sent me their standards, which are 9 pieces is what they said. So if you want to be part of this network in the Midwest, then you need to make sure that your notes include these 9 elements. Here's the first 4 on this slide. Identify the patient, specify the date of the encounter, and the visit number within the treatment plan. They really want to know where you are. That's like saying, well, I'm at milepost 15 out of 273. And it makes it really clear where you are on your journey. They want the daily visits to include the summary of the chief complaint. Why is this visit being done at all? What's their neuromusculoskeletal condition? Number 4, they want updated patient-specific measurable, subjective, and objective attributes. So that's pretty loaded, but that's kind of the S and the O in a SOAP note. Patient-specific, not just generic stuff, but that patient has this, and the next patient may not have that same thing. So it's very important to make sure it's patient-specific and it's measurable, as measurable as possible. So rating the pain is one way to make it measurable. Objective attributes like degrees are measurable, and that's important. It's easier to track. And number 5 through 9 for this group is they want an assessment of functional changes that are patient-specific. And so again, function identifies things like activities of daily living. And changes is a buzzword you're going to see over and over again. I really feel it's important for you to show changes, progress on your journey. Okay. Number 6, they want to see the current diagnosis, which could change. You might start with more diagnoses and, halfway through care, you drop a few of those because those things resolve. Number 7, they want procedure specifics. They want to know what the service was, where it was done, why you're doing it, and how long it took. And those are important because a record really should be like the script for a play, where if you look at this, you can actually see what happened, and you could hand it over to an actor and they could reenact that scenario. And if you simply say we did manual therapy, I don't know what that is. But if you explain what kind of manual therapy it was, where you did it, why you were doing it, and how long you spent, then it's easier for someone to reenact it. Right? And then number 8 there is the plan. And I think it's enough to just state in a daily visit, hey, our plan is to see him in 3 days and the reval is scheduled in 2 weeks. And then, of course, a note needs to end with some way to identify who the provider is with a signature that's either legible or next to a printed name with a date and time stamp, so that we can understand or know that the note was created in a timely manner. Okay, so that's from another authoritative source. Here's one last authoritative source of requirements for daily visits. This is Medicare. I pulled this out of the LCD, the Local Coverage Determination for NGS, or National Government Services, which, let's see, for many of you, that would be the upper Midwest, like Illinois, Wisconsin, and Minnesota, I think, is NGS, as well as the New England area. So for those of you who aren't in those areas, you have a Medicare contractor that also has LCDs for you. They're very similar to this. Most of them are similar to this, except for, so let's just say most of them. They're not all quite like this, but let's just go with this as a standard. Medicare requires 4 things, and you'll notice this has nothing to do with SOAP. They say that daily visits or subsequent encounters needs to have a history, a physical exam, documentation of the treatment given, and documentation of how the day's treatment fits within the plan of care. So this sounds a little different, and it's going to take a minute to match this up with a SOAP note. So I'm going to come back to this one, okay? We'll revisit this because Medicare is a gold standard. So hang on to this one, and we'll come back to it. Let's just look at a classic SOAP note for a few minutes, and I want to show you some examples here so that you can see how to bring this all together. Subjective, objective assessment, and plan / procedures. So I actually kind of like to have 2 P's in my SOAP note. A plan that says kind of where you are in the journey, and procedures, which describes what happened that day. All right, so there's your classic SOAP note and what will be in there. Let's take each piece of this and kind of dive in a little deeper, shall we? The first one is a subjective. And I think the most powerful part of the subjective portion of a note is what's in the patient's own words. Now, you can certainly capture this in paper records. Paper records can give you this information, but automated electronic health record systems can do this smoother because they often carry things forward. The danger there is you copy the previous subjective information, like patient complains of right-sided neck pain that's a 7 out of 10, and it radiates down the right arm. And you say that over and over and over again, it sounds a whole lot like the patient isn't changing or progressing. So my challenge for you is to try to include as often as possible something in the patient's own words, and put it in quotes even if you want, or just say patient stated this. That way, that note will not look exactly like the last one, no matter what, because the patients aren't going to say the same thing every time. So I strongly encourage you to include a quote from the patient in your subjective part of your note as often as possible. Regardless, the subjective should include information about each complaint by location. So for each complaint, let's say they got neck and low back problems, I want all 5 of those little bullets here to be identified. Where, how severe it is, character, description of it, the duration and timing, and things that make it better or worse. Those kinds of things should be there in the daily notes, so I know what you're going to be working on and what the patient's concerned about. But really key is change since the last visit. It's very important that you capture subjective changes. So a patient statement of functional change is my favorite. It would be the patient saying, I can walk a few hundred yards further before the pain stops me, or I can sleep 3 hours before the pain wakes me up, and last time it was 2. And so those are great quotes to show that this note is unique and not cloned or copied and pasted, and it focuses on function. So those are really powerful things to document in the subjective portion of the note. And I strongly encourage you to capture that. Use measurable attributes as much as possible. Things like the visual analog scale, a percentage of the time that this is a problem, degrees, like how far they can move. And as I said before, if you copy and paste this on more than just a couple of visits, it looks like cloning. So be careful and stay away from that. Here's an example, and this is just a record I created with my EHR system with PayDC, where I captured most all of that information. I want to point out one other nice thing that we've got in here, and that is I bolded some items here. And at the header in this note, which is cut off there, but it says I bolded the changes. So if I sent this note to a reviewer, they would see at a glance that 7 out of 10 is something new, and left arm, left elbow is a new area, and it's occasional, that's new. So the stuff that's in bold here is all stuff that's changed since the last visit, and it's easy to spot, and it makes it simple for my reviewer to identify that stuff. If you do paper records, try to think of a way to highlight changes from one visit to the next. As a reviewer, I hate it when I get a stack of 10 records, and I have to compare each record to the last one to figure out what's new. If you simply highlighted it for me, with a highlighter even, that would make my job so much easier, and I would just be your best friend, and I wouldn't give you a bad review, right? And then at the bottom, I even added some stuff in, patient statement. Patient reports that, this, and that. So I've got some stuff from the patient there. So there's an example of how you can capture most of this information for the subjective. Now we move to the objective part of the note, right? The O. This is stuff that's quantifiable as much as possible, stuff that you can measure. And so I believe that the objective part of a note should include support for segmental dysfunction diagnoses if you want to get paid to adjust a subluxation. And I think the best way to capture that is with PART, which is outlined by Medicare, PART. It's an acronym for how to do an exam that proves that a subluxation exists. And I love that. I think that's a great way to put it. I think that's something you should have in every note for every patient when you want to get credit for a subluxation or segmental dysfunction, which I think you need to have in order to support that they need to be adjusted. Now, you might think that you can adjust a patient without subluxation, but I think it ties things together so nicely that it should be that way, in my opinion. And then you also need to support other diagnoses. If you had, say, a diagnosis of myofascial pain syndrome, which is an M7-9 diagnosis, then you should have something in there that explains and supports why that diagnosis is still valid. Some palpation, some range of motion assessment, some stability, muscle strength or tone. And I chose those 4 elements out of the 1997 documentation guidelines for evaluation management encounters for the musculoskeletal system. In other words, I didn't make up what those are. I used standards in the healthcare and coding world. And this is where you can also put in some orthoneurals if you want to do them at daily visits that help establish if they have radiculopathy. You can really quickly retest, shoulder depressor and see if it, is still positive. You can also do OATS, which is things like the Oswestry questionnaire or the Neck Disability Index or the Functional Rating Index at daily visits, if applicable. I think that OATS are only good if they're less than 30 days old because of how Medicare used to require them to be done. So I think any outcome assessment you do more than 30 days ago is no longer relevant and can't be used to defend your case. But it's really, really important that you emphasize change since the last visit. This is where we need to know about changes. And if you copy and paste on more than a couple of visits, then it looks like cloning, and you should avoid that as much as possible if you can. So here's a simple daily visit objective listings where we can see some spinal findings. One is in bold because that one's new. One is gone. The C2 one is resolved. We have a description of the trigger points. Most of that's the same, but I do have some bolded items here that show that it's less severe. And then some other muscles have gotten a little worse. So I've just got some simple findings here that captures some changes from one visit to the next. So now we move to the assessment in a SOAP note. We've done the subjective, we've done the objective. We need to dump those things together in a bucket, stir them around, and look inside the bucket and try to figure out what our assessment is. The assessment is taking the subjective and objective findings and coming up with the result of them. So these are the kinds of things that could be part of the assessment. A diagnostic statement or clinical impression where you say what's wrong. Subjective progress, where you say, I know a minute ago I had the subjective stuff and I said the patient said they can sleep better. In my assessment, that means this. Objective progress, where you can say, I know just a moment ago, a few lines above here, I said that this muscle doesn't have as much problem as it did before. And so you can, in the assessment, you can take a moment to comment on that and say, hey, looks like the muscles are moving along based on my objective findings, something like that. This is where you can also comment on patient compliance or lack thereof. Hey, the patient was gone, that barriers to recovery. Patient was on vacation. Patient missed a few appointments. That kind of thing. Patient went on, went and lifted a box and it made things worse. That type of stuff belongs here. This is also where you can comment on percentage of completion towards specific and measurable goals. You can say, hey, we had a goal to get him to sleep 6 hours straight without pain, and we're about halfway there. We're at 3 hours right now. So this is a great thing to update at daily visits. And this is something we built into to my EHR system. And then you can say what phase of care you're in. Oh, we're in the relief phase of care. We're in the corrective phase. For the record, I'm not aware of any standard of what the phases of care, what verbiage is standard for naming phases of care. You can pick whatever you want, but I like the concept of phases of care because they provide benchmarks. They're like waypoints on my roadmap journey where I can say, hey, we've gone this far. And now so we're checking to make sure that we're, on the right track and everything's good. So we're going to continue on into the next phase of care. That's powerful in conveying benchmarks to third-party reviewers and helping them see progress. So here's an example of an assessment from one of my records, a fake record, but a record nonetheless from our system. It says, we're in the phase of care that's acute intensive. Here's my diagnoses listed out here. A prognosis for this patient is excellent, and here's a summary of that. Now, don't give them a prognosis of excellent if you think that you're going to treat them for another 8 weeks, because a prognosis of excellent implies that they're done in 2 to 4. So keep that in mind. And then we have our goals listed here. And then I've commented on what percent of completion. Looks like we've already accomplished this other goal. So we're going to need to set some new ones perhaps, or move them to the next phase of care, maybe. And so there's a little summary here of what's going on. Patient's progressing as anticipated. Intensity is slightly increased since the prior visit. This case is complicated by his anxiety, but short-term goals previously outlined are still expected to be achieved by the next evaluation. So all that is crammed into the assessment, and it really captures the story and helps us identify where things are going. And then we move to the P in the SOAP note, which I guess that sounds bad. We're not peeing in our notes, and I believe that P stands for plan and procedures. And so this is where you outline what's next, okay, where you're headed. This is where, if I'm on a road trip and someone says, hey, where are you guys going? You say, oh yeah, I just took this exit off of I-15 and I'm going to go on Highway 21 and we're going to, go head north. And here's what we've done so far and here's what we're doing next. So this is where you say, hey, today, here's what we did. We did chiropractic manipulative treatment. We did some modalities. We did some durable medical equipment. Maybe you gave them a back brace or something, or a TENS unit, and we provided some therapy. For each of these, you need to explain the details because, again, your notes should be like the script for a play. And here you can see that I've put in parentheses what else I think needs to be there for each of these. So just saying I did adjustments isn't enough. Say where you did it and what the technique was. If you provided them with therapy, explain what kind of therapy, where it was done, how long it was done, and what the rationale for that therapy was. We did this in order to improve the range of motion in the neck. Not simple stuff like that, but that explains it. And then give home instructions if necessary, or comment on them and say, hey, the patient is still following those same home instructions. And then outline the visit number and the date of the next evaluation. Okay, so this is where you say, yeah, this is visit number 5, and the re-exam is scheduled in a couple of weeks or around visit 8 or something like that. So here's an example of that from my notes. I've got, based on today's subjective and objective data, here's what we did. And each bullet here represents one of the treatments. And for each treatment, I've outlined the location, the frequency, duration, the rationale, and all that you need to know to understand why that service was done. And at the bottom, a little summary. Patient will continue with care plan as outlined, including neck stretches and that were taught previously. This was visit 4 of 10. She's due to return in 2 days. Next reval in a couple weeks. Patient received care without incident. So I've captured all that information. Okay, so there's an example of a note that captures most all of that. So that brings us back in full circle to what we were talking about a few minutes ago, and that is our friend Medicare. Right? I showed you this slide previously. This is the snip out of the local coverage determination, or LCD, for NGS, or National Government Services, for a Medicare contractor. And they've outlined that they think that daily visits should include 4 things. So the question is, how do SOAP notes and Medicare fit together? I never want you to feel like when you see a patient who has Medicare, you dread it because you're like, oh, I have to do extra work because this patient has different requirements. No, you need to come up with a single consistent standard and do it for every patient the same, whether they're cash patients or they have Blue Cross or they're an auto accident or they have Medicare. I think that there's a way to create a complete and thorough record that captures all of that for every patient, and you just have a standard that you follow in your office, and then you don't have to think differently about different patients. I don't want you to feel like you do less work on cash patients. For example, if you're in Colorado and you do WIMPIA records, that standard is the same no matter who the payer is. That's for your licensure. And many states have similar requirements. So if we look closer at this, we see that Medicare says that at daily visits, there are 4 things they really want to see. 4 things. They want to know the history, and they've got some details here, and we'll get into these. They want a physical exam, and they've got some explanation here in parentheses and then a list underneath it, so we'll go through those. And they want documentation of treatment given on day of visit. They want to know what happened, and they want to know how it fits within the plan of care. And this element number 4 is present for most Medicare contractors, not all. Some of you actually don't have this requirement specifically identified, but you know what? You should do it anyway. It's a good standard. Okay, it does a good job of outlining the plan and showing where you are on the roadmap, if you will. So here's how I make Medicare's requirements fit with a SOAP note. You can see here 1 through 4 is a summary of what the Medicare requirement is. They want history of physical exam, what treatment was given, and how it fits within the plan. And then in red, I put how I think that correlates with SOAP notes. I believe the history that Medicare requires is the same thing as subjective requirements for a SOAP note. And the physical exam that Medicare requires lines up with the objective and the assessment in a SOAP note. And the final 2 things, the treatment given and the fit within the plan, tie in quite nicely with the P, or the plan portion of a SOAP note, plan and procedures, if you want to make it SOAP with an extra P. And I think that is really, really key. So let's see how these fit together here. Just looking at history, Medicare's requirement that says that they require to see history, again, I think that ties into the S in a SOAP note. Medicare says they want to see these 3 things: review of the chief complaint, changes since the last visit, and system review if relevant. And then I've taken it on my own to say, hey, you know how you can say changes since last visit? You could, and some of you will say, well, wait a minute, how do I say that? Well, what if the patient says they got way better, but now they're the same? Well, you should document that. Don't just say the patient's the same, even though they felt better for a week and they haven't been in for a week. Document changes following the last treatment, and then changes immediately preceding the current visit. So maybe they didn't notice any changes until yesterday, even though it's been a week since they were seen. Or maybe they felt great for a week and now they feel the same or worse. Document those changes, not just this point in time, but summarize what has happened since they were last in the office, right? Capture all that information. Okay, so that's how Medicare's history requirements relate to the S in a subjective note. Medicare's physical exam requirement for subsequent visits ties into the O. And Medicare says they want to see an exam of the area of the spine involved in the diagnosis. And so what I suggest you do, and it's kind of copied from that Medicare LCD, document subsequent changes by updating the neuromusculoskeletal exam findings for all the diagnoses reported. So if you report a diagnosis of radiculopathy, at daily visits, comment on what you're evaluating to see if that radiculopathy is still relevant, make sure that they can see that. If you also have segmental dysfunction, then that's where you can put in part, and I think you need to have segmental dysfunction if you want credit for doing an adjustment. Now, Medicare has added here that a full repeat of part is not expected. And frankly, I disagree with this. The purpose of them saying that the part wasn't expected at daily visits is because they wanted the doctors to have the flexibility to, be in charge of their own notes and say what they want to say. But in my opinion, if you don't have part documented at a daily visit, then you don't have justification typically for a segmental dysfunction diagnosis. And if you don't have a segmental dysfunction diagnosis, I think it's hard for you to support that the patient needs an adjustment. So I think you should do part at every daily visit where you think they need an adjustment. That's my opinion. It's not required, but I think you ought to do it. And I think you should do that for every patient, not just Medicare. I think you should do that for your cash patients and your PI patients and everyone. If you do a significant and separately identifiable examination, then you can bill a separate E&M code with a 2.5 modifier. If your objective findings, your physical exam includes a full exam, then it can be separately billable. And that's a discussion for another time, okay, about when E&M is significant and separately identifiable from a typical daily encounter that includes the adjustment. So that's the physical exam requirement of Medicare and how it ties into the O in SOAP. If we look at the rest of the physical exam requirement for Medicare, it also includes the A in SOAP. These 2 bullets from Medicare's requirements, they say they want to see an assessment of changes in the patient condition since the last visit. And this is, again, changes. That word keeps showing up again and again. So this is where you take a moment in a daily visit and you compare previous findings to the current findings. You might say, on a road trip, you might say, well, we were passing through Ogden, Utah, and now we're in Tremont, in Utah, so we've gone further north. You just comment on that. Or with the patient, you say, at first they couldn't flex at the waist at all, and now they're bending forward slightly so they can, brush their teeth or whatever. Medicare says this is a quote from Medicare: evaluation is ongoing. Signs and symptoms must be rechecked during the course of treatment. Their fear is that chiropractors are doing not evaluating the patient and not commenting ever on their signs and symptoms. They're saying that you claim that you wait until the re-exam to recheck things. No, you need to check it all the time. You should always be evaluating the patient to make sure that the care you're providing is, required. And then Medicare wants you to list and update diagnoses if possible. If the diagnosis is new, then add a new initial treatment date in item 14 on the claim form for Medicare patients. That date of first visit. If you have a new diagnosis and starting a new care plan, then you can restart that date on the claim form. Now they also want an evaluation of treatment effectiveness in the A portion of a SOAP note if you're using the SOAP note model. So this is where you need to say, hey, we had a goal, and I'm going to acknowledge that goal. I'm going to say we made it, or we're not making it, or it's staying the same. So it's very important. If patients haven't achieved goals, this is also where you can document the clinical factors that contributed to the inability to meet the goals that were stated in the care plan that were outlined initially. This is where it's really critical to say something like, patient is responding as anticipated, but then go a little further and say, as evidenced by, and this belongs in the assessment, right? Say why you think they're responding as anticipated. Don't just say that because it's a cookie cutter thing you say on every patient, but give specific evidence that's unique to this case. Okay. And then it's wise for a medical legal reasons to say patient tolerated treatment without incident, in case they come back and say that you hurt them, or if they didn't tolerate treatment, they felt worse, then comment on that as well. Make sure you record accurately what occurred. And this is where you modify treatment if necessary. This is where you say, we're going to do these next stretches, but I don't think there's time yet. We're going to put them off for another couple of weeks, that kind of thing. If you can capture this stuff, then you've got a great assessment and you've satisfied Medicare's physical exam requirements of these two big bullets there. Okay. And then the final requirement from Medicare is they want you to outline what treatment was given and how it fits within the plan. So this is where you could say, well, we did this chiropractic manipulative therapy, and here are the vertebrae and the technique I used. And by the way, we also adjusted L4, even though we don't expect to get paid to treat L4. That's just a compensatory segment. I'm a full spine adjuster, and I feel like if I don't address the lumbars, then the neck won't resolve. But I recognize that I doesn't meet the requirements for medical necessity. So, but I still want my records to reflect everything that happened. And so I need to record segments that I adjust that aren't medically necessary, that aren't payable, because my notes have to reflect the full encounter, like the script for a play. And this is where you would also document the modality and therapies not payable by Medicare, but Medicare needs to see what you did with the patient. And I think instead of saying, hey, I did, these settings on this machine and I did all that, it may be acceptable to also just say, hey, I outlined all the settings for the machine at the treatment plan dated 6/12/19. So I think that's sufficient. But you can also just say, hey, if you real quick, here's the settings. That's fine too. And this is also where you can say this is a treatment. You put the treatment number to let everyone know there's a plan. Let everybody know I'm headed north. I've gone 10 miles in the last few minutes, and I'm going to go 10 more miles in the next couple minutes. Or from this visit to the next. Here's what I expect to accomplish. Forcing you to put a number on a treatment plan makes it also easier for a reviewer to understand that you're part of this much larger roadmap, right? You're looking at this journey, and they can understand exactly where you are and where you're headed next. So again, in black, I have the 4 requirements for Medicare for subsequent visits. And in red, I've got where it fits within a SOAP note. In other words, what I'm trying to tell you is you can do a typical SOAP note and capture what Medicare requires without having to do different notes for Medicare patients. So here's one sample template. This is sort of where the rubber meets the road here. Here's a sample template that captures what I've outlined previously without too much detail. But more or less, your notes should look something like this. All right. If you want to satisfy, remember at the beginning of this, I told you what was required for one state board. I told you it was required for Optum and Blue Cross and for Medicare and for a provider network. I believe that if you have all these elements that you see on your screen in your typical daily notes, that you will satisfy all those entities, all those authoritative sources in your SOAP notes. In your subjective, you can list the chief complaint, but I don't need you to tell me at every daily visit all the details of the chief complaint necessarily. Just remind me what it is. But you don't have to put their entire health history there again. That's redundant. If it was a car accident, I don't need to hear details of the car accident at daily visits. Just tell me what their main complaint is and where it's at, and really emphasize changes. In the subjective part of a note, I really want to know about changes from one visit to the next. In the O portion of the note, the objective, really there's only 2 things that you should have objective findings for. You've got the segmental dysfunction to support your manipulation and any other diagnoses you have. And the segmental dysfunction ties nicely into part or pain, asymmetry, range of motion, and tissue and tone changes, which are Medicare's requirements to justify segmental dysfunction. And I think that that those should be present and easy to spot on every visit. And then other neuromusculoskeletal findings to support your other diagnoses. I think that's the purpose of the objective. And those should be changes. Focus on changes from the last objective findings. And then in the assessment, there's a lot you could do here. So I tried to kind of summarize them here. In the assessment, you say what the diagnoses are. You comment on the progress from the subjective and objective findings. And here I've indicated that with S and O. So you say, the patient said they sleep better. I found less spasm, whatever. You comment on those here. And then you have the patient response to care. You have what percentage of the goals have been accomplished or completed. You outline complications like, say, hey, I thought we'd be further along, but the patient missed a couple visits. And what phase of care they're in. They're in the acute phase still, but we feel like in the next week or two, we can move over to the strengthening phase or whatever you call it. And then finally, the P for the plan, you outline what treatment was given today with all of its rationale, location, and so on. You update the goals if necessary. You review the home instructions. You say, hey, I taught them exercises 2 weeks ago, and I'm going to do the same ones, or I've added a couple exercises. And you explain what visit number we're at and when the next evaluation is. I believe, that if you are able to capture all of this in your daily notes, that you will satisfy those authoritative sources and you will create what I call the perfect SOAP note, right? Is it perfect? No. And this is where we'll open this up to questions. This is where you get a chance to challenge me and say, wait a minute, I don't like that, or I think that's too much, or that's too little. So let's talk about it. Let's see if as a group we can improve upon this. I've done my best to give you a great example for a SOAP note, but now we've got a few minutes here. Let's talk about how you can make this, how you can bring it all together, or what you don't like, whatever. I reviewed at the beginning of this payer requirements from various authoritative sources and what they want to see at a daily visit or a treatment visit or a subsequent visit. And then we tied together SOAP notes with Medicare's requirements so you can see how they fit. All right. And that, my friends, is the perfect SOAP note. Okay. Again, it's always a pleasure before we go into the questions to share this with you. I hope that you found this as useful as I've worked hard to make this focused and relevant for you. If you want to look at how to create EHR-based notes and you're in the market for that, email me right there and we'll set up a demo and I'll show you PayDC and how it works and how it accomplishes all the stuff I've shown you here. Happy to share that with you. So with that, I will pause and see if we have any questions.
Thank you, Dr. Gwilliam. And yes, you have quite a few questions. So let's see what we have first. To indicate objective change. Oh,
Oh,
oh, sorry.
can you hear me okay?
I can.
Yep.
So first question, y'all, sorry, we have technical issues from time to time when our speakers are not broadcasting live from home, but traveling around the country. To indicate objective change to passive joint restriction or muscle spasm, are there accepted adjectives as mild, moderate, severe, or a numerical scale that can be used?
Great. So it's funny, Dr. Boaz, I see submitted this question. He's a regular. Always asking me some tough ones. Here's the thing. I think mild, moderate, and severe are very common, but I personally prefer quantifiable findings, so numbers, because everybody pretty much understands that 8 is bigger than 4. And so if I put a numeric scale on it, I think that's less subjective. And mild, moderate, severe can mean different things to different people. So I'm not aware of a standard one way or the other. I think, and I could be wrong here, it's acceptable to make up your own numeric scale and just say, a scale of 0 to 10 on anything, any findings you have. There are certain standards for some findings, such as the Oxford scale, I believe is what it's called for muscle testing. But I think it's great to put numeric values on things because it's more relatable because numbers are a universal language. All right, so that's my opinion on that one.
Wonderful. Okay, our next question. If I remember, Mercy has language for stages of care.
Yeah, and actually I scrolled ahead and saw that this doctor submitted an answer or answered his own question later. I've looked at Mercy guidelines and I've forgotten that. He says that they do have the names for stages of care. They have acute, remobilization and rehabilitation, and lifestyle adaptation. Those are fine. I'm not aware of there being a standard. And Mercy guidelines, just as a side note, are controversial. Whereas because some payers have used them kind of against providers, and some providers are not. And when they came out, it was kind of a issue. So there's some value in Mercy, the Mercy guidelines. I think that it's acceptable to choose your own names for stages of care. And if you want to have backup for it, then go ahead and use those ones from the Mercy guidelines, but I'm not a huge fan of the way they're worded. But that's your call. Oops. Next question.
Is it enough to state CMT was made at segmental noted in objective section?
So, it may be, but here's the thing with that is you might top-hit a patient and say in your objective section, hey, I found some problems from T4 down to T8, but all you adjusted was T5 and 6. And so I think in many cases, it kind of depends on how you document things, but I think you need to be specific in the plan and identify exactly what was done. And if you only note objective findings specifically for those segments that you do adjust, then I don't see a reason why it wouldn't work. And I think you guys are noticing here, I'm being kind of wishy-washy with my answers, but I think that there's room for your own impressions here, as I kind of hinted at the beginning of this. So this is just my suggestions and my opinion, albeit I like to think of myself as an expert. So, if you feel like the information is conveyed that tells the story properly, like a script for a play, then you should be fine.
Excellent. Okay. Let's see. Is there a need for your diagnosis codes and CPT codes to be in the SOAP note for the day, like in the assessment and plan section?
Yeah, so here's where I'm going to reference theirs. Noridian is the Medicare contractor for where I'm located. And Noridian suggested in some of their guidance, maybe 4 years ago, 5 years ago, they said, we like it if you list the diagnosis codes within your daily notes, just so we know what they are. It doesn't mean you have to go in and restate them or write up a diagnostic statement in a paragraph that's identical to every other visit, but just to say, by the way, these are the diagnoses that are relevant to today's treatment. And that is, they went on in this Noridian document, this Medicare guidance, they said it's a good idea. They didn't say it was required. So I'm going to just say it's a good idea. I think it's wise to list your diagnoses at every visit, because then anyone who's reviewing the case can quickly, grasp those. I suppose you could also just say diagnoses are unchanged, see visit such and such, where they were outlined in the care plan. But it makes it easy for the reviewer just to see the 4 or 5 top diagnoses if you just drop them in.
Excellent. Should daily SOAP note include functional changes each visit?
So this gets back to what I said. I feel like if your notes are the same for more than, say, 3 visits, then they look cloned, or it implies a lack of progress. So I think that functional progress should be documented as much as possible. However, I acknowledge, and I would hope that an auditor for an insurance company would also acknowledge, that sometimes there isn't a lot of functional change from Tuesday to Thursday. But you should document it as much as possible. Ask about it at every visit. Get it in the patient's own words, or comment it on the assessment when you do percentage of improvement on your long-term goals. So I think that functional improvement at daily visits is ideal, as much as it exists. And if you don't show any over 5, 6, 7 visits, I think that an auditor could have a case to say that your care was necessary.
I'm going back to this slide. We have someone in the audience who wants to know if this is for an exam visit or a daily visit in the A&P of the SOAP note.
So I think at the beginning I tried to introduce the idea that this was focused more on those daily visits. On the roadmap I was showing you, where there's kind of the big evaluations, and in between there's little treatments or keys visits. My focus on this presentation today was more on a typical daily visit in between, not a full-on evaluation or exam, which might include more thorough testing, more of a in-depth assessment of whether or not their goals have been reached, and a establishment of the care plan to update it or add new things in the case of a re-exam. So I was focusing more on a typical daily visit here than a full-on examination.
Can percent of improvement be used, or even percent of treatment plan completed, as opposed to a number? Percent
of treatment plan completed, like if you said I had a plan for 10 visits and I've seen them 4, so we're 40% done. I guess I hadn't thought about it that way, if that's what you intended by the question. I like numeric values. I think you've gathered that. I think it's very powerful to convey messages through numbers because it's a universal language. And so I guess that's fine. I'd have to think about that one a little bit, but I think it's okay.
Okay. Are techniques like network spinal analysis considered medically necessary?
So I'm no expert on network spinal analysis, but I believe I've seen it specifically mentioned in some private payers' policies, like Aetna, for example, where they say there's not enough. They'll take techniques that are, how should I say this respectfully, techniques that aren't mainstream. I mean, I guess it's common, but they'll go in and they'll say, this technique doesn't have sufficient evidence to support it as effective. And they have lists. Payers will go right out and say it. So if you can convey musculoskeletal findings with musculoskeletal progress and tie the segments to the areas where the complaints are and all that, then yes, with that technique. But if that technique relies on other factors that are not more supported by current evidence that is recognized by payers, then yeah, you'll have a hard time. I hope that answers that. And I don't mean to disrespect any technique in particular. From the perspective of a payer, a reviewer, they look for any excuse not to pay. And if you have a technique that doesn't rely specifically on musculoskeletal findings that are, research supported, evidence based, I guess, then they can use that as an excuse not to pay. Even though you and I both know you're helping your patients, so I want to make that clear. So I don't know if I answered, but I'll say probably not. How about that? So very wishy-washy.
Should a verbal analog pain scale be reported on daily SOAP notes? For example, 775 to report that the patient has an intensity at 7 for 75% of the day.
Yes. Well, that's a short answer. Yeah. I mean, it's numeric. The verbal numeric rating scale has been used for decades, and I can't remember where I learned this or read this, but it's scientifically valid, and it's, even though it's not based on function, it doesn't tie into function as directly. I think it's one great quantifiable measure to use at daily encounters. And I think payers are okay with it. They like it.
Let's see. With the treatment number, should it be in the S and the P of the SOAP note, or is it okay to have it just in the S?
So, in my template on one of the last slides I showed you, I put it under the P for the plan. But in my sample note, I don't know if it was shown in the sample note, I can't recall, like the kind of notes that we generate with my software, it's in the header. We put it the header just because it's kind of it helps kind of give you reference for where you are. So as long as it's in the note, I think it's acceptable, but it just, in my view, I think it belongs in the P. But I don't see a problem with it being in the subjective. It's not subjective information though, right? But I don't think it would hurt too much. I just think it makes more sense in the P, or like I said, I put it in the header before the SOAP section.
Okay. I'm going to probably mispronounce all of this. Do you see question number 14?
Yeah, I do. Go for it. I want to hear you try to pronounce it. It's great.
You are such a mean friend. Dr. Thomas, here I go. I identified 3 causes of neck symptoms: ligamentous laxity, loss of lordosis, and disc herniation. Do I need a SOAP note for each injury? How bad did I do?
That was really close, actually. You were like 98%. That was good. So just to kind of summarize what you're saying, Doc, if you find 3 different types of injuries, here's the thing. I think that you need not a separate SOAP note, but you need to acknowledge within the SOAP note each problem the patient has. And I think of it, in my mind, more like they have a neck problem, and here are the things that explain it. So that's one SOAP note that explains the neck problem. Within the same SOAP note, you say problem number 2 is their low back, and then you go in and explain the causes of that. So I guess that's no. You don't. I don't feel like you need a separate SOAP note for each injury. You need a separate entry for each problem within a daily SOAP note, a separate entry for each problem you're managing, because you might be managing the neck differently than the low back, and you might expect a different outcome for one or the other, or you might be providing different services for one or the other. And I think you need to make that distinction. That kind of goes back to my first few slides about the problem-oriented medical record, where you take each problem the patient has and you address the diagnosis for that problem, the plan for that problem. In the SOAP note, you acknowledge that problem and say, hey, for problem number 1, the neck, here's what I'm doing, and here's what's happening, and here's where we're getting. And for problem number 2, the low back, we're doing this. But I think that the causes of a single problem can certainly, fit within one SOAP note. Great question.
Excellent. They were great questions. Challenging for me, and maybe not so much for you because you were just.
No, you did great. You did great.
I want to thank everyone for hanging in there because we went 15 minutes over. Although that is kind of our thing when Dr. Evan is on our webinar series, because he always gets a lot of questions. But if you're like me and you think of questions after the fact, although he is traveling, he does check his email. So please email evan.gwilliam@paydc.com. If you're looking at, new EHR software, I will tell you they are one of the companies that we definitely recommend that you demo before making a decision. Amazing software. So there's a lot of options out there, but there are really only like 4 or 5 that we, really recommend that you demo before making a commitment. So please check that out. Reach out to him. You can schedule that with him directly. Bonus this week, we're doing a webinar tomorrow as well with Dr. Adam Rodnick, Dr. Ray Foxworth, and Miss Yvette Noel on balancing your practice in the new year. So if you haven't registered for that one already, please go ahead and do so now, because we're going to be doing it on the GoToWebinar platform instead of our webcast platform that has a limit of like 500 attendees, and I think we're already at over 400 registered. So register for it. Make sure you're there. It's going to be a great webinar. Next week, we're going to be talking about social media and marketing with my very good friend, Dr. Nick Silveri. I'm going to tell you what, we became fast friends because he did something completely amazing, but I'm going to make you wait till next week to find out what amazing thing that he did that completely wowed me and opened the doors for me to get to know him, his company, all of the wonderful things that he is doing in social media and marketing, and brought him to our webinar series for you next week. So go to ChiroHealthUSA.com/webinars. We have all of our webinars posted going all the way into April. Amazing speakers coming up in the next couple of weeks. We have Dr. Miles Bodson, we have Baron Hoig, Dr. Jay Greenstein, Dr. Mark Santa, Dr. Heidi Havoc. So we have some great people coming here to educate you, answer your questions. So make sure you register early. We look forward to seeing you next week, same time, same place. Dr. Gwilliam, safe travels home.
Hey, thanks so much.